Okay, thank you, Dr. Dresden. So moving on to next presentation, which will be mine. So again, my name is Sung Jang. I'm the interventional endoscopist at the Cleveland Clinic, and the title of my presentation today is a direct oral anticoagulants primer for gastroenterologists. So having said that, the focus of this talk, to be honest with you, is the acute brisk upper GI bleeding, so life-threatening. So if we're talking about actually also pertinent issues of the elective procedures. I think Dr. Dresden covered it, and there'll be a slide here and there, but our focus is on the acute active bleeding where a physician like Dr. Tu encounters not so uncommonly. So here are the main objectives of my discussion. So I'll discuss some time in terms of roles of endoscopy in management of upper GI bleeding, in terms of especially the timing of it, because that is pertinent as to whether we should consider reversing these medications or not. And it moved on to one second. The management of the DOACs, in terms, as well as a little bit on the antiplatelet agents, I'll touch upon during the acute GI bleeding. And lastly, I'll provide several slides on what are the available guidelines and consensus on the Gastroenterology Society, both domestic and international. So before I forget, here are the main key points. Number one, the timing of the endoscopy should be based on the patient hemodynamics, not on the fact that if the patient has been sufficiently reversed in terms of their coagulopathy. And let's be frank, we do not have any head-to-head data that exists supporting the better patient endoscopic outcome, that is namely the better endoscopic hemostasis, no need for second look, 30-day mortality. On those data, when we took a look at or discussed the issues of reversing the DOACs. And lastly, in terms of when we consider reversing the DOACs, it should be given to very selective circumstances, which depends on the timing of the last dose, signs of persistent severe bleeding, and also, as Dr. Dresden mentioned, in terms of their ability to clear the drugs, whether it's a renal or hepatic related. So we came a long way from a couple of decades ago where we actually had a mortality related to acute GI bleeding anywhere between 11 to 12%, now down to 6 to 8%, which I think is also in large part our ability to perform endoscopic hemostasis, but at the same time the development of drugs such as PPI actually has a monumental contributions. We know that the mortality tends to be higher during the weekend admissions as well as a public holiday. And also if the patient is admitted to the hospital, which don't deal with this in day in and day out basis, the mortality tends to be higher. So, I've heard so many times from my senior fellows and mentors, kind of the bad adage, all bleeding eventually stops, which kind of is true. But I guess the point that we're making is the death directly attributed to the hemodynamic collapse from the exsanguination is of a rare exception. It's not a norm. In fact, more than 80% of the death is attributable to the worsening of their underlying comorbid conditions. That said, we know some of the risk factors that are related with the increasing mortality, namely the age, as well as some chronic comorbid conditions such as a cardiac, renal, as well as end-stage liver disease. So in terms of assessing severity of the GI bleeding, I think Dr. Dresden mentioned that the major GI bleeding, again, one of the components is hemoglobin greater than 2 grams per deciliters. But I think one can also parse it a little bit and say critical GI bleeding is a hemoglobin drop greater than 25% from their baseline with the signs of hemodynamic compromise or signs of end organ damage. Now, each part of this life-threatening bleeding, whether it's intracranial hemorrhage or interperitoneal bleedings, they have the pros and cons of their presentations. As you know, in our specialty, our bleeding declares itself very robustly and effervescently, so we get to find these things pretty quickly. But if they have a brisk bleeding, sometimes it lacks a time to have that equilibration. So when the ER, for example, or the patient gets admitted upstairs and check the hemoglobin, then they may be erroneously high, but that doesn't mean that they are actually critically ill at that point. So to risk stratify the patients, there have been several attempts of developing a risk scoring system, and 2 of them were developed from the European societies where medicine is socialized and rationed to much extent. One is a Rockwell scoring system, which was created to assess the mortality, which incorporates both clinical as well as endoscopic data. The other one is Glasgow-Blatchford score, which again was published recently around the similar time, but this actually assessed the need for intervention, that is namely the hospitalization and doing the endoscopy. So I'm going to give you the table that exemplifies the Rocco score. So you have variables or data on the left side, and you have different points that are assigned to it. So for example, within the columns or the context of comorbidity, if you have a metastatic cancer or a renal failure and say renal disease, you automatically earn 3 points. And based on the hemodynamics, if you have a signs of significant hypertension, blood pressure drop systolic is less than 100, you already got 2 points on it. So you already have to begin with 5 points without anything else. And if you actually add them up and tally them up, and you actually can have a pretty nice and validated risk in terms of mortality as well as rebleeding rate. So for example, as I mentioned, if the score is 5, your risk of mortality is now about 11%, whereas the risk of rebleeding is about 25%. So that is pretty helpful, except that really is cumbersome and not many people can memorize that. So to augment that issue, there was a newer system or scoring system that was created by Saltzman and group in the Brigham, which called the AIMS 65. So it uses very simplified 5 metrics, that is the albumins, INRs, mental status, blood pressures, and age. And it only assigns points, 1 point each, and based on that, based on the scoring system, one can rather reliably detect the risk of mortality, which, by the way, this study has been validated with this new sets of patients. So this goes back to the whole point of timing of the endoscopy. So when do we need to do the endoscopy? So there has been a consensus that was published as well as the opinions from the key opinion leaders. So the consensus from the international group states that early endoscopy within 24 hours of a presentation is recommended in most patients. And this has been echoed by the experts such as Lauren Lanes at the Yale, who says the patient with upper GI bleeding should generally undergo endoscopy within 24 hours of admission following resuscitative effort to optimize hemodynamic parameters. So why do I actually stay in this? Because of actually this slide, which I find it pretty important. So this was actually a study that was published in GIE in 2017. So they are looking for so-called the golden time of endoscopy. When is the best time to do the endoscopy that has the lowest mortality? So graph on the left is the patients who have a hemodynamically stable bleeding. Graph on the right is the patients with hemodynamically unstable bleeding. The line on the top is the high ASA classes, so sicker ones. On the bottom is the lower ASA class. And as you can see, there is that bell or reverse bell shape, and you can see that somewhere between 18 to 28 hours is where there is the sweet spot for the endoscopy. So in other words, between 18 hours to 28 hours of the admission is the best time that you're going to have endoscopic outcome. And people can make a lot of conjectures to it. My guess is, and I think this is probably you would agree, is that that's the time we were able to adequately resuscitate the patients. So the patient's hemodynamic parameters will allow us to be as aggressive as we need to be with the medications and due diligence in terms of doing the endoscopic interventions. So when we discuss the reversing the agents or giving the anticoagulant agents, basically it's a balance game between the reducing the risk of thrombotic events versus the increasing risk of bleeding. And when we reverse it, obviously it's vice versa. So cardiologists and some of the hematology specialists use these CHA2 scores on the patients who actually have a cardiac or arrhythmias or atrial fibrillations. Who are the people who will benefit from getting these anticoagulant medications? So this CHA2S2 score combines several parameters such as the hypertension, diabetes, history of strokes, and again, much like other scoring systems, you tally them up. And for example, if you have a CHA scores of greater than 5, you have a risk of CVA about 1 in 8 per year, so 12.5%, which perfectly justify, in my opinion, patients getting these medications on a long term. So I'm going to just spend just 2 slides on the antiplatelet medications, and the reason is pretty simple, which I'll state anyway. There's these medications, the newer ones, so-called the P2Y12 antagonists, such as the clopidogrels and ticagrelors, they don't have a reversing agent, so only way they irreversibly bind the platelets. So only way for us to augment that or help that is actually platelet transfusion if necessary. So in terms of pharmacologic perspective, you have to just wait it out. So that's what this table is saying, that only in terms of emergency, if you were to consider aiding your endoscopic attempt, is a platelet transfusion. And I can count in my opinion, as to when the patients were bleeding on these medications, how many times we end up actually giving platelets. More often than not, if the patient needs endoscopy, you just bite the bullet and do it. So that is the limitation of these antiplatelet agents. What about anticoagulant agents? So warfarin is the prototype, as Dr. Dresden has talked about, and I'm not going to spend too much time repeating it. So it's just that, those direct factor 10A, they have this SA, so rivaroxaban. So this is a very clever way of the companies to come up with these names, apixaban, so you have this 10A hidden somewhere there. And there's also a direct thrombin inhibitor, which is dabigatran. So, and as Dr. Dresden mentioned, not all the DOACs are same, right? Different mechanisms of action. He discussed that. He also mentioned the dabigatran is 80% renal excretions. Also, there's a small study that was published in 2017 said the risk of the GI bleeding is not the same. For example, apixaban was associated with a lower risk than the dabigatran when it comes to the risk of GI bleeding. So this is the watered-down version of GI. We're plumbers, so we can't remember that coagulation cascade, so I'm just going to focus on that part. So the factor 10A basically inhibits the propagation part of it. That's where the apixabans and the rivaroxaban fits. The direct thrombin inhibitor basically prevents the convergence of fibrinogen to fibrin. That's the dabigatran. So the point of this table is this. Most of them have a half-life of 12 hours with the exception of betrixaban, which again, as Dr. Dresden says, we don't really use here. And their onset of action is pretty immediate, so within an hour or two, you're going to see the robust effect of these medications. So we talk about reversing agents, and again, some of these things that were mentioned by Dr. Dresden. So one is the idarucizumab, which is very specific for dabigatran. The little older and a little bit more tried and true, but not necessarily efficacious, is the protein complex concentrates, and the nucleotide on the block is andexanet alpha. So just very quickly, the idarucizumab is a specific monoclonal antibody. It preferentially binds to dabigatran over the native thrombin. Its onset of action is immediate. Its so-called terminal half-life is less than 10 hours, but it's very limited to direct thrombin inhibitors. Now, interestingly, although that's 80% cleared by the renal, if I'm not mistaken, the company who manufactures this doesn't say that it needs to be renally dose adjusted. Is that true? Okay. Now, much tried and true and robust literature exists with the protein complex inhibitors. So it comes in the two forms. It's either 3 components versus 4 components. Mainly, we're talking about the 4 component, which contains the factors 2, 7, 2, 9, 10, and some of the factor 7 as well. The onset of action is very quick, and you don't need to match the blood type. And some of these things can be actually stored in a room temperature, which is, I guess, the benefit of it. So the andexanet alpha is the modified recombinant inactive form of human factor A. So they bind, and basically they take away the factor 10A inhibitor from the circulations. So onset of action is within minutes. The reversal of the anticoagulation effect of the factor 10A with this medication actually persists about 1 hour or so after the infusion is completed. So it's not really long-lasting effect. So there are 3 studies that I would like to briefly mention, and a couple of them, actually Dr. Tu will go into details. So one is the effect of the idarucizumab on the dabigatran. This is called the Reverse S study, which was published in New England Journal of Medicine. So which incorporated more than 300 patients, of which 137 was GI bleeding. What they were looking for is the cessation of bleeding in terms of how long did it take, as well as any adverse outcomes such as thrombotic events. So in this study, they reported 2/3 of patients actually had a successful and confirmed bleeding cessation within 24 hours. But having said that, they also reported a 30-day mortality of 11%, as well as thrombotic events of close to 5% within the 30 days of the reversal. Despite the study concluded that in emergency, the situations idarucizumab rapidly, durably, and safely reverse the anticoagulant effects of the dabigatran. So PCC, as I said before, multiple studies exist. So, but one pertinent study that we have is the post-hoc analysis comparing the GI bleeders who compare with just plasma infusion versus the PCC. And this is a small study that only incorporated 20 patients on each arm. What they were looking for is a surrogate, so time to procedure. How long did it take from the patients to actually be admitted, transfused these medication, had endoscopy done? And their study concluded that with the PCC, time to endoscopy was statistically significantly shorter, 18 hours or less than 18 hours versus 24 hours. But if you remember that the graph that I showed you, the golden hours of endoscopy still lies between that 18 to 28 hours. So in terms of meaningful endoscopic hemostasis, does that translate into it? We can question that, because even with the 24 hours, I am not sure if that's any detrimental for the patients actually having endoscopy at that time. So lastly, this is the study on the Anticoagulant, which looked at the reversal of the factor Xa inhibitors. So this is so-called the NX4 clinical trials. I apologize for the busy table, the graph on the right side. So this incorporated 352 patients, of which close to 250 patients actually met the criteria for an efficacy evaluation. Of those, 62 were actually had a major GI bleeding. And all these people actually had a wide range of the factor Xa inhibitors, including apixabans and rivaroxaban and so forth and so on. So they actually had a little bit of a subjective definition of good versus excellent hemostasis. So they based this on the base of on the blood loss. So if you lost less than 10% or close to 10%, that was considered as excellent hemostasis. If it's less than 20%, it was good hemostasis. So that's what they were looking for. So nevertheless, this study concluded that about 82% of the patient had excellent or good hemostatic efficacies overall. 85% of the people under the headings of the GI bleeding actually had either good or excellent hemostasis. Again, you turn around and talk about the adverse events and safety issues, 10% of the patients actually had thrombotic events within 30 days. Of actually 3% of the patients actually had thrombotic events within 5 days of the index and the infusion. So, it is not without any precautionary tales at this point. So let's go to what's pertinent to us in GI. How should we manage these DOACs in the setting of acute GI bleeding? The intervention actually, again, depends on the severity of bleeding. We talked about that. Timing of the last DOAC is critically important, which I'm sure Dr. Tu will talk about. The creatinine clearance or renal function, as we discussed. So for non-life-threatening bleeding in the absence of renal dysfunction, the study actually had concluded that temporary cessation is sufficient as an anticoagulant effect for the DOACs as it wanes off. You wait for this to wane off after the discontinuation, so within 12 to 24 hours or so. But there are also consensus that came out from the American College of Cardiology as well as some of the several GI societies. So these are some of the robust or the important highlights that they recommended. So reversal agents should be reserved only for the patient with a life-threatening bleed. Use of 4-factor PCCs, as I said before, is in patients taking vitamin K antagonists or factor Xa inhibitors recommended. Now, this study was published before the Anticoagulant study, so in that sense, this is a little bit of an older recommendation. Patient with the major GI bleeding while taking dabigatran should be administered idursulfimab for the reversal. For patients with the GI bleeding, restarting oral anticoagulant within 7 days has been associated with the better outcomes, including improving survival and reduced thromboembolic risk. So they said within 7 days. That's what the American Cardiology Physician recommended in 2017. Now, if we talk about our own society's recommendations, the most recent recommendation, or perhaps more salient and robust recommendation, came from the Joint Asian-Pacific Association of Gastroenterology and Asian-Pacific Society of Digestive Endoscopy. So this recommendation was published, I believe, last year. So in regards to the oral antiplatelet therapy, again, just one slide on this, they do not recommend withholding both agents. We already practiced that. Patients on the PPI continue the aspirin while stopping the clopidogrel. In patients with a drug-eluting coronary stent, they recommend the early resumption of these clopidogrels or other P2Y12 receptor inhibitors, probably within the 5 days of the effective endoscopic hemostasis. So how about warfarin specifically? So again, recommend withholding the warfarin. This is no-brainer. They also recommend 4-factor PCC plus a low-dose vitamin K. Again, the importance, the utmost importance of my presentation is this: do not delay the endoscopy of life-threatening bleeding at the expense of trying to normalize the anticoagulant effect. Rechecking the INR after the reversal therapy is routinely not recommended. Again, bridging is only recommended for quote-unquote high thromboembolic risk patients. So moving on to the DOACs, they recommend reholding DOACs for same reason, for the effective hemostasis. So this activated charcoal thing is funny. In fact, I asked Dr. Chu about this, but their consensus still recommends activated charcoal for life-threatening bleeding if the last dose of DOAC was within 3 hours or so. How many of you guys have done endoscopy with the activated charcoal in your stomach? Yeah, that's exactly my point. So, and idarucizumab is for the treatment of life-threatening bleeding in a patient with the dabigatran, and no vitamin K for bleeding associated with the DOACs, and no bridging therapy, as Dr. Dresden mentioned. Is there some difference, subtle differences? The answer to that is yes. When it comes to patients on the warfarin, the Asian Pacific Society recommends low dose of vitamin K, whereas the European Society recommends a higher dose. When you talk about the resumption of the warfarin, the Asian Society recommends actually much more quicker, within 3 days of the adequate hemostasis, whereas interestingly and surprisingly to my discovery, European Society recommends resumption within 7 to 15 days following the bleeding event. Now, and as to when to resume the DOACs, the Asian Pacific Society again recommend within 3 days, whereas ASGE, ESGE says not specified or ask cardiologists. I presume there aren't cardiologists here, so how many times when you ask these questions you get really helpful short sentence question, yes you can resume, no you cannot resume, because that's really hard to come by for me, actually from my cardiologist. So in summary, in vast majority, endoscopic evaluation should not be delayed in severe life-threatening bleeding in an attempt to reverse coagulopathy. Again, I emphasize that. The cessation of the dual antiplatelet therapies, or DOACs, often suffice in terms of managing the coagulopathy in setting of upper GI bleeding, and the utility or the use of the reversing agent should only be considered in the very most dire life-threatening circumstances. But we still don't have a clear agreement and idea as to the resuming the DOAC. And as to when is the good time to do so. I think the belief is that sooner the better, and that still needs to be borne out in much future studies to come. Thank you very much for your attention.